With the advent of stratified medicine, which means that we have multiple treatment options for cancers, that it's important to figure out to decide which patient benefits from which therapy most, so that you need a marker for that. And this is, these are predictive biomarkers. So to define the right predictive biomarker is not as easy as people would expect. When you look at the literature, there are more than 100,000 papers on possible biomarkers, and about 100 made it into the clinic, showing that most of the biomarkers are less robust than you would expect from an ideal biomarker. So just describing a little bit of the problems and what would be the precautions really to ensure that the biomarker which is used is really validated in the right way, which to date unfortunately is less regulated as it would be for when drugs are tested in clinical trials. So it should be kind of like the same way to evaluate the biomarker, and then it should be validated not only for robustness of the analytical technique, but also of the pre-analytical handling of the samples, and to have the right standard operating procedures to obtain the sample, and then also to validate that it truly addresses what you are thinking you address, which is also sometimes a little bit more complicated than it appears on the first sight. The biomarker will definitely be something which is tumor specific in order, but also therapy specific. And then actually it will not only be tumor entity specific, but also patient specific. When you take, for example, that circulating tumor DNA in melanoma is a little bit of a nightmare, because unlike other tumors, it's only a few patients which are truly having it in the blood. So it would be first essential to test the patients initially to make sure that they are the ones who would benefit from this. And this is really showing that it will be highly individualized as well, almost as much as the therapy is.